So today I am asked by Dr. Alok to speak about artificial intelligence in cardiovascular disease, and apart from my role as a cardiologist in an academic institution, I also delve a little bit with biomedical engineering and am interested in new technologies, so probably it gives me a little insight into how these things work. I would say that artificial intelligence term is something that we all know about, but it's also something that we all hardly know about. Let's start off with the skeptical people and with the fears that all of us have. And this is a very nice editorial that just came up with European Heart Journal, and it says that if we look at the humanity over the ages, and if we start with the prehistoric times of stone ages, human beings were using both their physical and intellect capacity to maximum. But with the advent of industrial revolution somewhere in the late 1700s and the early 1800s, the physical work kept on decreasing, but the human beings were also using their intellectual work at even higher levels than before. So we were very intellectual species of animals, and that's how we grew. But with the advent of artificial intelligence, apart from the physical work, the intellectual work of humanity is also decreasing, and how these things will play out in future is a very open-ended discussions, and we can continue to debate about it. We'll come back to this slide later. I also feel that many a times artificial intelligence is used in a very loose and a generic term by most of us, not only as physicians, cardiologists and doctors, by society as a whole, where a good joke in early 1900s in US was that me, my neighbor, his wife, her brother and his dog, we all are software engineers. So when we start to use terms which are purely scientific terms in a very generic manner, then probably there are some issues of communications that may arise. So we have to understand that artificial intelligence is all about advanced computing and mathematical and statistical models that encompass a host of computing kind of subspecialties like machine learning, like deep neural networks, like pattern recognitions, like chat boxes, virtual companions, robotics, and so on and so forth. So it has to be considered as a cumulative of a very vast number of advanced computing technologies, and what particular element of these or a combination of these elements we are using in our experience in our clinical settings. This we have to understand if we want to draw some logical conclusions about what we expect the machine and the computers to do and what the real output is. So we have to have a little bit of understanding, not details, we're not engineering, but we have to have a little bit of understanding about what's the difference between deep neural networks, machine learning, pattern recognitions, cluster algorithms, and so on and so forth. So it's term not new. The philosophy of artificial intelligence and computing is based on the Alan Turing's experiments of the late 1940s and 50s, and we'll come to Alan Turing in a while. The term itself was coined in 1955 by John McCartney, but it was not up till late 90s when a computer defeated Garry Kasparov in a game of chess that people really start to take notice that the machine can beat the most highly intelligent people of the world. So this is the time that the real interest in artificial intelligence computing started, and now everywhere from our Swiggy apps to our Ola to mobile technologies, everywhere we are surrounded, even without realizing we are surrounded by these algorithms and these data-driven predictive models. Alan Turing. How many of us know about Alan Turing? Very interesting story, very interesting story. The guy died at the age of 41 years of age by suicide, with cyanide suicide, and he was from UK, and he was deployed as a mathematician from Cambridge. He was deployed to break the Enigma code during the Second World War, which the Nazis were using, and he developed these electromechanical machines that could predict what the Enigma code was saying, and that was instrumental in defeating Germany in Second World War. And later on, he developed a host of other algorithms that laid the foundation of basic computing, and then computing changed the world later on. So Alan Turing, but unfortunately, in 1951, he was accused of homosexuality. He was sentenced to either a life term in jail or a chemical castration. He chose chemical castration, but he kind of died by suicide. In 1909, he was pardoned, and he was Prime Minister of UK, publicly apologized to public about the ill treatment they have done to Alan Turing. In 1919, a £50 note had Alan Turing photograph, and in 2021, he was labeled as the most influential human being of the 19th century in 2021. So he's the father. So it's nothing new that we are talking about. But let's come back to our talk about AI and cardiovascular disease with this case example. We have this 74-year-old lady who has progressively exertional dyspnea. Her BMI is 29.9. She is hypertensive, diabetic. Her NT-proBNP is in the range of 170. Cardio CT ratio in X-ray is just about 50-55. And the E by E dash is 13.9. And she suffers from dyspnea on exertion. So the question before the house is she a patient of HFpEF, or is it just dyspnea because of any other cause? If we come to the basic core diagnostic methodologies that we use, and if we apply the European Society and various society algorithms to diagnose whether she is a patient of HFpEF or not, we'll see that her NT-proBNP gives her 170, NT-proBNP gives her a 1 point, E by E prime of a 13 again gives her a 1 point. So it's not more than 5 points. So classically she is not a 100% diagnosed case of HFpEF, but she's a probable case. And then you have to go for all sorts of invasive monitoring. But can there be an easier way to predict that? So can AI and deep machine tools help us to answer these following questions for her? Is she a patient of heart failure? That's the first question. Are there any specific therapies that can be beneficial for her? That's the second question. Can her health be monitored digitally and without human interface? Is she at high risk of hospitalization or death? And can we do anything about it to decrease these events? So let's see if machine learning can help us answer, if AI algorithms can help us answer this question. So forgive me for this kindergarten looking cartoon, but this is not my cartoon. This is from AI and medicine, from one of the articles that went out from Mayo Clinic, I think. I don't remember the exact thing. And they say that mostly in medicine, it's the algorithms that are used which are classified as the classification algorithms or the clustering algorithms. Now, you have to understand that you feed the machine sufficient amount of data, and then you can tell the machine, let's take the example of an X-ray. We tell the machine that this X-ray, look at the pixels of this X-ray, and this X-ray is of pleural effusion, and this X-ray is not of pleural effusion. And you feed a 1,000 normal X-rays and 100 X-rays of pleural effusion, and then the machine learns to recognize whenever it sees the pleural effusion, it will recognize that it is a pleural effusion. So you are telling the machine that this is a pleural effusion, this is not a pleural effusion, just this much, and the machine learns to predict, and that is called as the classification algorithm. The second algorithm is that you don't tell the machine what it is. You feed the machine as 1,000 X-rays, and it will just cluster. It will pick up all the pleural effusion, and it will tell you that, oh, this cluster looks like one group, and this is the cluster which, like, for example, can be a pulmonary embolism or a pneumothorax or a pulmonary edema, and it can classify, it could cluster these X-ray based upon their similarity, but the machine will not know which cluster it is, and you will have to ultimately tell the machine that this cluster belongs to pleural effusion and this cluster belongs to pulmonary edema. So these are the basic two kinds of clustering mechanisms that are used, and we will discuss about this thing later on. Now this is my slide. And let's take an example of, if you want to say that there are different types of dogs, different species, different color, different sizes and species and colors of cat, and they eat different kind of food. And let's also put in another variable, they have different levels of exercises. Now, if we feed the life history of a lot of cats and dogs into them, can we develop an algorithm to say that which of these animals is going to live longest on what diet and at what level of exercise? Now, we can do it in basic research methodology, in basic statistical method, let's say a multivariate or regression analysis as we call it. But that again has got a limitation, because basic mathematical and statistical models will not work if the number of variables become very, very high. For example, if you look at this variable. Now this is again a very, very simple problem of trying to cluster various patients of heart failure with preserved ejection fraction. And look at the variables. On one hand, you have QRSs, you have the GFRs, you have the sodium potassiums, you have the echo parameters, you have the clinical parameters, you have the ECG parameters, everything going down. And then the calculation would look somewhat like this. So this is not humanly possible by basic mathematical and statistical models. You will have to put in advanced statistical model, which will in this case look like how your brain thinks at very levels, and that's why these kinds of layered approach to clustering is called as the deep neural networks. Because they mimic the neural mechanism, the neural functioning of a human brain. So, and now we can have look at the ECG, and we can have the ultra high resolution ECGs, and we can look at the ECGs and predict, even before the classical intraventricular disturbances or classical LBB has developed, we can predict that which of these ECGs is going to develop heart failure in future, or let's say low ejection fraction in future. And there have been studies, they selected group of people with heart failure with preserved ejection fraction and mid-range ejection fraction. And they looked at the ECGs changes and predicted that this particular group is going to have normal EF over a period of time, and this particular group of ECGs are going to have low ejection field over a period of time. And it was seen that in red line, which represents that those ECGs that were initially classified as low ejection fraction, up to 40%, 35% of them went on to have the ejection fraction of less than 35% over the next 10 to 15 years. But those ECGs that were initially classified as normal ejection fractions went on to develop low ejection fraction of less than 35% only in about 10%. So that's a very, very stark study, very, very important studies that can tell us about the long-term predictability of how an ECG is going to behave, how an echo is going to behave, how a patient is going to behave over a period of time. And for that you need huge and horrendously large amount of data being fed in the machines, and then statistically kind of predict about what is going to happen, and that's called as the validation cohort. Again, you have algorithms that can pick up a single frame of echo and then can predict heart failure with preserved ejection fraction, and you can predict HCM just by looking at ECG, even when the very obvious signs are not present. Now, coming on to the clustering algorithms that we have already talked about. In heart failure with preserved ejection fraction, a lot of data was fed, and I think this was, what was the study for the spinal lectone? TopCat. This is from the TopCat data. This is from the TopCat data in which they classified these patients about the three P1, P2, and P3. Now the computer did not know what's going to happen to these P1, P2, P3, but it was realized that the P3 group had the worst prognosis, and these were the groups who had obesity, who had diabetes, who had higher inflammation factors, and this particular group also had a better response to spironolactone. So it's not only that you can predict the outcome of a particular group by such kind of clustering, you can also predict the response to therapy. Thereby, you can have, rather than giving one particular therapy for, let's say, an HFpEF patient about this will work or this will not work, you can have subgroups in that same patient group and say that this particular subgroup is going to be benefited by SGLT2 inhibitors, this particular subgroup is going to be benefited by spironolactone, something like the CRT therapy in heart failure. When CRT was given to all heart failure with patients, it did not work, but later on you realize that you have to base these therapies on QRS, and you had very high failure rate in the end. But when you identified the particular subgroups that are going to respond to CRT, then probably the real magic of the therapy started to happen. And this is again a similar clustering in HFpEF patients of sweetheart and check heart failure, in which you have different clusters and the response of different clusters to different kind of drugs. Moving beyond the heart failure with preserved ejection fraction, in our example, you can actually train the machine, and the robots are not exactly like robots doing their activity, but you can ask a machine to mimic a behavior, let's say, of a physician nurse. And this was the system that we had developed along with a company called as Evolco system, and we implemented it in our cardiology OPDs along with various other OPDs of the Department of King George's Medical University. Essentially, what it used to do, there's a kiosk like you have an airline kiosk. The patient comes, feeds in the basic data, and his blood pressures and ECG are taken. And then, based upon the symptoms that he has told and the parameters, the machine will ask certain questions, the further leading questions about whether you have this or not. And then you would have an outpatient boarding pass. You see the third image here, outpatient boarding pass that would be given. So when the patient used to enter the doctor's chamber, he already had a basic working plan of diagnosis and probably some suggested treatment also be given. The work of a physician nurse, it led to, most importantly, an improvement in the turnaround time of a busy OPD, a less involvement of the clinician, less work for them. But at the same point of time, surrogate, which no one realized earlier, but we realized later on, it generated huge amount of data for us, for all the patients who were coming out, and seamless manner, the data was captured and we could use that data later on for our clinical studies. Another thing that in cardiovascular diseases where we have been involved with as a department and individually as myself, in the prediction of cardiovascular diseases in individuals. We have various scores. We have the QRIS, the WHO, the Framingham risk scoring system. But the traditional risk scoring systems have multiple failure points. Firstly, the risk factors being selected are initially random based upon the trial list or based upon the known conventional risk factors that are popular in that particular subgroup. So risk factor selection process is not very scientific. Second, there is no feedback loop. What happens when you collect the data over a period of time and new risk factors develop, or one particular risk factor start to go down? And also, with every passing stage of patient's disease, his risk may change because of the treatment and the compliance to treatment. So feedback loop is not present. It's not accurate in Indian subset. It has been most of the risk scores are not accurate for Indian subsets, and prospective trials have not shown them to be very, very accurate either. So this was an artificial intelligence-based AI-CVD risk scoring system that was developed by Microsoft and the Apollo group of hospitals, and it was validated at AIIMS and KGMU, in which based upon the 50 commonly measured variables in an outpatient for cardiology OPD, they narrowed down with deep neural networks to 22 risk factors, and these 22 risk factors were used to predict cardiovascular risk. As you can see, the number of risk factors that were studied were much, much higher than any other risk score that was traditionally being used, and the machine would give the patient a risk score as well as the optimal score for that particular age. So if a score was less than 1 of the optimal score, it was low risk. If it was 1 to 1.5 of optimal score, it was moderate risk. Or if it was more than 1.5 of the optimal score, the patient was classified as high risk. And you could actually put the preventive cardiology kind of thing, secondary prevention methods, intensive lipid loading, intensive lifestyle modification, and a patient who was earlier of high risk would now go into a moderate risk or a low risk. This also we have proved in a very large study which we are about to publish. So this was, in this particular patient example, the risk score was given was 4, the optimal was 2, so it was 2 times, so the patient was high risk, clearly high risk. And it was much more sensitive, specific and accurate with every other known cardiovascular risk scores. The last thing is telemonitoring. For coronary artery disease and arrhythmia, the basic telemonitoring is of ECG, but for heart failure, we need to measure both the fluid as well as the arrhythmia. Arrhythmia leads to sudden cardiac death, but the sudden decompensations and presenting back to the emergency is because of excessive fluid load. Generally, traditionally, we used to measure body weight and you could advise the patient, but then you see a very, very important thing. This is a very important slide that you must try to imprint on your souls, is that when the fluid overload starts to happen, the time between the when fluid overload starts and when it clinically presents to an emergency, there is a gap of around 2 to 4 weeks. So if you have methodology, very crude methodology like a body weight, or a very advanced methodology like a wearable device, a CardioMEMS device of St. Jude's, and other devices that are being developed right now, if you can predict the fluid overload, the very simple way to do it is measure the body impedance, which changes according to Dr. Daljit might agree that we have advanced pacemakers that actually would measure the impedance and would warn the patient with a beep about the elevation in the body fluid volume. Because of change in impedance, it can be done, and if you can predict the body volume, you can send the patients back for excessive diuretic therapy. And then, so now the advanced technology is also so much that you can listen to a patient's voice on phone, and from the change in the patient voice over the phone, you can predict fluid overload, and you can warn the patient about getting diuretic or getting a stick. So we come back to this old slide. What do we think right now, whether the artificial intelligence, let alone medicine, but in overall humanity, will it lead to a catastrophic downfall? The answer is not there, but for medicine, at least in the short-term medicine, we know the answer, that artificial intelligence will not replace doctors, but doctors using artificial intelligence will certainly replace the doctors who are not using it. I thank you, and I really apologize for extending my time.
Thank you, sir. I think all of the queries he already have answered. So now I request Dr. P.R. Sinha sir and Dr. Rohit Tiyari sir to please come on the desk. Every year we give award to one of the best editor of Heart India. So this year I think Heart India all have started with the input of Professor Rishi Sethi sir. So this year best editor award is for Professor Rishi Sethi sir. His contribution and his support to me is like anything. Whenever I ask for any support, he is always there. And Heart India Journal is Scopus Index is because of all his contribution and blessings.